Welcome to the session on the impact of Copay Accumulator adjustment programs and the landscape of the 2020 qualified health plans. I'm Stephanie Hengst. I'm the manager for policy and research at the AIDS Institute. And we're a nonprofit based in Washington, D.C., where our federal policy takes place. And we have a program office located also in Tampa, Florida. And I'm so happy to be here with you all, and I appreciate the invitation from the Hemophilia Federation of America's invitation to speak today. So my plan is to provide some background information on Copay Accumulators, what they are and how they work, where they are and who is implementing them, and why the advocacy community is taking action against them. So I'll walk through the research that the AIDS Institute has collected on these policies and 2020 health plans across several states, and I'll talk about what is happening with state and federal policies related to Copay Accumulators. In June, the AIDS Institute published a report called Copay Accumulator Adjustment Programs, putting insurance company profits over patients. So we've been working on this issue for several years and recognize the need for a comprehensive and consolidated resource on Copay Accumulators, which this provides. And it also presents a solid background on the information and research that we again collected on the 2020 state marketplace plans. So this presentation will be kind of the Cliff Notes version of that report. So I highly recommend checking this report out for more detailed information. And we intend to continue to update this report with data for the upcoming 2021 plan year. And I'll just say that we have focused our research in this report and generally more on the Affordable Care Act marketplace. But I will say that we do know that large employer plans, so those of us who get our health insurance through our work, those plans also have Copay Accumulators in them, but it's just been a little bit harder to access that information and find out what those health plans are doing specifically. So that's been our focus thus far. And as we talk about Copay Accumulators, I want to frame the issue in the broader context of health insurance and how it's a problem that's been created through changes to health insurance plan design. So health insurance companies over time have evolved and they've been finding ways to make beneficiaries pay more and more before insurance actually kicks in. So, when we look at trends in the way that they're designed, we've seen sharp increases in deductibles over, say the last 5 to 10 years. The number of formulary tiers, so where our drugs are placed on the tiering system, those have also increased. And they've also added specialty tiers to the top of that increased number of tiers total. And again, those higher tiers and the specialty tiers tend to be associated with co-insurance instead of co-payments. So instead of having a flat copay for your specialty drug of even a high copay of maybe $150 or so, people who have a drug that lands on that tier will now pay a 40 or 50% co-insurance. So you're paying 50% of the list price of the drug. So those are significant ways in which plans have changed their the design, and individuals, patients, beneficiaries are having to pay more out of pocket. So in response to the changes in plan design, and as patients are having to pay more out of pocket, they've also had to seek financial assistance through copay programs, charitable foundations, GoFundMe, to help cover the costs of their copays and co-insurance. So Copay Assistance is really important, but it's ultimately a Band-Aid solution to this problem. So typically as co-payments are made by a patient, when they visit the doctor's office, or those co-insurance or co-payment payments made for a prescription drug, those things are supposed to be adding up incrementally to reach that deductible, which, as I just mentioned, even that threshold has now increased also. So it's harder and harder to reach that deductible level. And this is where Copay Accumulators have come in. So now insurance companies and pharmacy benefit managers, or PBMs, are saying that if you pay for your expensive drug that's now in that really high tier with support from a manufacturer assistance program, that money is not going to count. It won't count towards your deductible. So So this is a really simple overview and comparison of how copay accumulators operate in a plan versus when there's not an accumulator in a plan. So behind the scenes, the payments that are covered by that copay card or copay assistance, they're not adding up to the deductible. So you still remain with the deductible basically untouched even after you've made payments if you're using a copay card. And remember, again, the important part is reaching the deductible, because when that is reached, that's when your insurance kicks in. So again, this isn't just about affording your prescription drugs, which is kind of the first line of this issue, but it's really about also all the other medical services that you would need, especially individuals who have high healthcare needs. If they're not able to reach that deductible, all of their other medical services that they're in need of aren't going to be covered by their insurance. And what's an additional layer to all of this is that the money from that copay card or from the copay assistance, even though it may be coming from a manufacturer, it's still money, and that is still money that the health plan is keeping. So in the report that I had mentioned previously, we have a much more detailed example that shows the breakdown of the costs that the patient incurs and that the plan keeps over the course of the year under both of those scenarios, the no copay accumulator versus an accumulator. So it really demonstrates kind of the difference and the magnitude of what is happening in terms of patient costs and what the plan is keeping. So again, I would point you to that if you're interested in looking at that kind of level of information. And again, consumers that are living with chronic conditions like hemophilia, MS, HIV, or cancer, they're relying on copay assistance to afford their high-cost medications that are otherwise going to be unaffordable to them, and especially in cases where there is no lower cost or generic available. And it's also really important that all of us as consumers and patients in particular understand that their coverage options, or what's within their coverage options, so that when they're shopping for a plan, they can find one that best fits their needs, and that they'll be able to plan accordingly for their healthcare costs throughout the year. Again, especially if you're somebody who has high healthcare needs and you have high costs associated with your health, you really need to be able to plan out at the beginning of the year, for the rest of the year, how are you going to be able to pay for your medications? And, again, we're talking about people here that are covered by insurance. So, you would think that this wouldn't be as big of an issue. Now that I've talked about copay accumulators in terms of healthcare policies and insurance plan design in kind of a higher level way, we'll move into more of the real life application and examples. So for our research, we looked at 9 states in particular to do a really deep dive on their copay accumulator policies in the ACA plans that are offered in each of those states. So I'm going to be using Florida as an example as we walk through this, but if you're interested again in those other states, and it's nice to kind of see how every state varies and do a little bit of a comparison across the states, that report has all of this information in it. So the first step in the process of pulling this information and finding out what issuers' policies were on it was documenting the issuers that were participating in the marketplace for 2020 in each state. So in the case of Florida, there were 9 issuers. And what this shows is a kind of a quick status snapshot of those issuers and their copay policies, copay accumulator policies. So it gives kind of a yes or, yes, they have a copay accumulator in their plan, no, they don't, or NBPP aligned. And I'll talk much more about the NBPP, but for just quick reference, when you're looking here, this designation means that the plan has a modified policy on copay assistance and copay accumulators. So in this case, they will count copay assistance toward the individual's deductible for a brand drug or for a drug that doesn't have a generic equivalent, again, as long as there is no generic equivalent. So it's a modified policy. It still means that there are many people who whose assistance won't count towards the deductible because there may be another generic drug in that class of drugs that's available. So for Florida, 8 out of the 9 issuers had some form of a copay accumulator policy in it. Again, that includes those NBPP aligned. And I'm just going to point out here that you'll see Florida Blue and Florida Blue HMO, which is the health options plan. They have a double asterisk, which I'll again explain later, but I just wanted you to keep them in mind as we walk through this. So for each of the issuers' plans, we searched through their plan documents, and that could be their summary of benefits and coverage or the evidence of coverage, whichever the document is that would really outline what coverage you would get if you were to enroll in this plan. And these are not easy to find. That is kind of one of the main takeaways of all of this research that we've done, is that this information has not been easy to find, nor always the documents. They're not always linked on either healthcare.gov or the states that run their own marketplace on their websites. You have to search for the issuer-specific website to find the right document. And then within the document, you have to find, the very specific information and language and policy information, which is often buried within, as you can see here on the right side, within hundreds of pages of health insurance legalese. So again, we wanted to collect, the information, the actual policy language on it, and in part for my own sanity, in case I couldn't find it again, I linked to that information so I can more easily track back to it later on. Let's see. So here are a few more examples of the policies that we found in the Florida plans and what each plan has documented in terms of their language. And what this exercise helps with is to demonstrate that the language between issuers can vary significantly. So after you find the policy, you first find that document that would explain what coverage you have, and you find the language, then you come to the point where you have to interpret the language. And again, this is often written in, language that's not typical, the layperson language of just reading your average information. It's difficult, it's vague. And so there were a couple instances where even as I found it, I had to ask somebody else and get their expert opinion on, what direction are they actually standing on this policy? And then at the top of the slide, you'll see for Health First, this plan in particular, there was no written documentation on the issuer's policy on copay accumulators. So how to follow up, I ended up calling a customer service rep or a consumer rep, and they were able to confirm to me, like, as I said, I'm interested in this plan. If I have copay assistance, will it count towards the deductible? And they in fact confirmed that it would not. So therefore they did have a copay accumulator policy. But how would we expect a patient to know this? Even very savvy patients and or a patient advocate that might be helping somebody navigate this kind of an issue, how would they know, one, to maybe find it? And then if they're onto it and they know where to look for this information, they get to this part and they think, oh, I found a plan that might work for me. It's not going to, block my copay assistance, only to realize later, many months into the plan year, that in fact there is a copay accumulator policy in the plan, just wasn't written anywhere. So this all really underscores how opaque issuers have been about these policies. And this is just the last slide of the language, so you can again see the variation that we found. But CMS has also made a really big deal about arming beneficiaries with sufficient information about their health plans in order to make them smart consumers, so they can make good decisions about their health care. And from CMS's perspective, it's a driver of cost for them, for issuers, but it's also a driver of cost for patients, as they're selecting a plan. But how are we, how is a beneficiary, how are we as good consumers supposed to be well informed if the issuer is not upfront about this information? So as we looked at many of the plans across the different states, we began to realize that you couldn't really make an assumption about any one issuer. And Caresource offers this perfect example. So Caresource offers plans in many states, but in these 3 states that we did the deeper dive on in particular, and in the 3 states, they had 3 completely different stances on copay accumulators. And to be completely honest, it's unknown as to why they would do that. I mean, geographically, they're not too far off from one another. Politically, same thing. So it's unclear, maybe what was at play in these states and in that particular, the issuer's decision-making process for why they had different stances. So in addition to doing a deep dive on those 9 states where we pulled each of the copay accumulator language for all of the plans that we could find, we also did a high-level search across all 50 states to determine if there was at least one issuer in the state's marketplace that had a plan with a copay accumulator in it. So this was more of a high-level yes-no kind of project. And here in this list, there are 33 states plus DC that do have some form of copay accumulator policy in a plan offered in their state. And I will say, though, how, as we just saw in one of the previous slides about Health First in Florida, where I was unable to find documented copay accumulator policy, there's a chance that there could be other states that didn't make it onto this list and would fall into that same category where perhaps, the documentation wasn't available or, couldn't find the documents at all, that kind of a thing. So, yeah, this kind of shows how pervasive that copay accumulator plans have spread. The other thing that I will note that I think is important is that in many areas and states, there are oftentimes issuers that only offer in certain areas of the state or certain counties. So while, again, using Florida as an example, there are 9 issuers in Florida, there were definitely pockets of the state that had maybe only 1 or 2 issuers that offered plans in their area. So if you are trying to, again, be a savvy consumer and you live in a region that only has 1 or 2 issuers offering plans in your area, then you don't really have an option. So I've provided a lot of information about these policies, but when you again take a step back and really think about what this means for patients and healthcare coverage, ability to pay for prescription drugs and medical services, what it comes down to is that, again, copay accumulators have become more widespread. So just as I said, they're in many, many more states than were the previous year, and we anticipate them continuing to spread. So that means patients are having fewer and fewer options to select a plan that best fits their needs, and especially if they're somebody with a chronic condition and relies on specialty meds, their options are slim. And these policies are really confusing. And issuers and insurers have done nothing to really help that transparency. The language is ambiguous, there isn't consistency across states, and even from year to year, an issuer may change their stance. So all of that to be said, policymakers can do something about this. Oops, and I realize I forgot to show the slide of all the states. So again, I'll just quickly recap. So this is the slide of all the states plus DC that had a copay accumulator in it. Or in them, and it's not exhaustive. This research continues, and the documentation is just so difficult to find that it's possible that I wasn't able to come across it. All right, so catching back up. So the first avenue of advocacy that we attempted to influence policy and regulation from the federal level was to work with other patient groups in coalition called the All Copays Count Coalition. And the steering committee members met with HHS, or U.S. Department of Health and Human Services, and had conversations with them to educate them on this issue and to prompt them to issue guidance or memos to issuers about this information, because we felt that it was a violation of the ACA guidelines around the amount of money issuers could collect from individuals. And then also, as I mentioned about, how confusing this information is, we wanted to point to the lack of transparency on the information, and that it was conflicting with their own rules on providing information upfront to consumers. So just to prepare you all on this particular slide, it's a bit like watching a tennis match with lots of back and forth. So hopefully you can all stick with me as I walk through it. So coming back to that NBPP, the NBPP is the Notice of Benefit and Payment Parameters, and it's an annual rule that HHS issues, and it contains lots of regulations on a whole slew of things, and it basically dictates how issuers can regulate in their state and what issuers can do in the future year. So in April of 2019, so the top row is where we're starting. In April of 2019, HHS issued their 2020 NBPP. So again, that would be for the 2020 plan year. And in that rule, they said that issuers must count copay assistance toward the beneficiary's deductible if the drug had no equivalent. So that was a big win. And I kind of mentioned this again at the beginning when I was talking about the NBPP aligned. And for many patients out there, for many disease states, for many drugs, there is no generic equivalent available. There's no lower cost available. So for those individuals, this was a really big win. In addition to that, there was also a requirement that was built in to create an appeals or an exceptions process for those who use a brand name drug, but there is a generic equivalent available, but perhaps for whatever reason, they must be on the brand name drug. They could gain access, to the same approval process and have their assistance count towards their deductible. So this was really great. However, this good news only lasted a short time. So a few months later, in August of 2019, HHS issued an FAQ jointly with Treasury and with the Department of Labor, saying that they would not enforce this rule in 2020. So they were putting a pause on it because it could be in conflict with an old IRS rule issued in 2004. So this was before the ACA had been signed. They had been operating under, without conflict for many years after the ACA was enacted. But they said, we're going to put a pause on this. We don't want to put anybody in a position where they could be in conflict with IRS. So I'm going to take a quick pause there and talk about those Florida Blue plans. So let's revisit those that I had mentioned had the double asterisk. So originally, Florida Blue had drafted their plan design and written their policy documents after the NBPP came out in April, and they were aligned with that. So we're going to call this one the good one. They were aligned with the good policy, and they in that slide they would have been designated as NBPP aligned. However, when the August FAQ came out from HHS, they immediately flipped their stance. They issued an addendum to their plan policy saying that their previous policy is being amended and that is being replaced with their new policy. And the new policy was an accumulator in place, so a traditional copay accumulator. So their language said, we may not apply manufacturer cost share assistance program payments to the deductible or out-of-pocket costs. And so they had flipped again, their stance. But I also want to note that in addition to flipping their stance, the language that they use, we may not apply, is very vague. And so it's going to leave, people again confused which direction they're going to go. So they were clearly following very closely what HHS was saying in each of those rules that were issued in the April and then the August. So that was bad news. So back to the timeline and of the NBPP. So the FAQ had also stated that they would make a final determination when they released the 2021 NBPP. So in May of this year, the final 2021 NBPP was released. And what it essentially said or states is that issuers may use their own discretion as to whether or not they will accept copay assistance and count it toward the patient's deductible and out-of-pocket costs, regardless of a generic. So now we're back to to no good. This, takes away the progress that they had made the year prior. And what it also takes away is any protection for patients that have no access to a lower cost alternative. So people who only have their brand name drug, the no generic, they have no option to select a different drug, and they have now been forced into a position where their copay assistance isn't going to count toward their deductible. So then now we're down to the last line. Most recently, in light of the impact of COVID-19 and the impact that it's had on patients' access to healthcare, U.S. House members have introduced a bill that would delay the enforcement of the 2021 NBPP. So the most recent one, it's going to put a pause. It would put a pause on that for at least a year, for up to a year after the public health emergency was lifted. So that means that all issuers would have to go back to the previous NBPP, the good one, and help patients get through this time of COVID, which is hurting people in many different ways and hurting access to prescription drugs and just general care and treatment. So hopefully you all stayed with me through that. It was kind of confusing, but hopefully it came through clearly enough. So really, the success stories on Copay Accumulators lies in the states. So while all that back and forth was happening at the federal level, advocates in states were also working hard to protect patient access to prescription drugs and protect copay assistance. So in 2019, there were 4 states that passed legislation that required issuers to count payments made by or on behalf of the beneficiary. So that includes third-party payments such as vouchers or manufacturer assistance, and that must all be counted towards the beneficiary's deductible and out-of-pocket costs, which is great. So that's been a huge success. So first, legislation was passed in Virginia and then West Virginia, followed by Arizona and Illinois. And all of these, the bills are, they're slightly different in language, but they essentially ban copay accumulators in their marketplace plans for their states. I will note that Arizona's was slightly different from the other 3 in that it was more of that NBPP aligned, whereas the others didn't have any exceptions or exemptions regarding, if there was a generic equivalent available. It was just any copay assistance must count towards the deductible. In Arizona, they had that modified version. So if there is a generic equivalent available, then the copay assistance won't count. But again, they also had built in that appeals and exemptions process. So that's good that, again, there's still the option for individuals to potentially gain access to or have their copay assistance be counted towards their deductible. And the most recent good news is that in Georgia, the governor has signed the most recent bill to ban copay accumulators in the state there. So I think the other interesting thing about these states when you look at them is that they're not the Californias and the New Yorks and the states that are often thought of as the most progressive and so on. It's really a wide variety of states and political stances. And so I think it's great that these legislators in the states and the governors there have recognized the importance of protecting patients' access and their copay assistance and what that role that it plays in this system. So this year, unfortunately, with COVID-19, many state legislatures were derailed. So it's hard to know exactly how far other states may have gotten in passing legislation. But this list shows that advocates were working hard across the country to build momentum toward introducing and passing legislation to protect patient copay assistance. So in some cases in this list, legislation was introduced. In other cases, there were just patient group interest, and they were working together to get to the point of introducing legislation in their states. So this is really great to see, and we hope that it continues. So as we're continuing to advocate for policies that protect patient access to care and treatment, these are some of the key takeaways and messages that I think are really important that we use when we're talking about this issue. So first, copay assistance is really a necessity. It's important, but it's again becoming a necessity that until health plans change their designs, their structure, patients will continue to need help affording their prescriptions. So that's a key one is, we try to frame it in a positive way of, let's talk about the negative copay accumulators and more about the importance of, how patients need copay assistance, and it really helps them afford their drugs, it helps them stay healthy, and it can lower healthcare costs in other ways because they're staying out of emergency rooms, et cetera. So then also, these copay accumulator policies are just really putting patients in the middle of the fight between insurance plans and drug manufacturers. And it's patients who are literally paying the price in both literally and then also figuratively when they're not able to access their prescription drugs. And again, their health is going to deteriorate and they're going to be harmed in this attempt to leverage the patient in this argument between the two industries. So then I'm actually going to skip down to the last item on this list, in that, an argument that we hear constantly, and it's not just from issuers, but we also hear it from policymakers, and we heard it from HHS, that copay cards drive patients to more expensive drugs. However, there is an abundance of research and evidence that shows otherwise, that, when given the option between a generic and a more expensive brand drug, patients choose the generic drug. I think prescriptions written now, like 90% of prescriptions are written for generic drugs, 90%. So again, patients, if they can, they're going to take that cheaper option. And that means that most copay assistance programs are really written for specialty prescription drugs that have no generic equivalent. So these are not just your run-of-the-mill, average drugs. These are very specialized medications that, again, are high cost and there's no generic equivalent. So the assistance programs have been developed specifically for that. They're not just for any old prescription. And then finally, when you look at prescription drugs, drug claims data across the whole market, and you're looking at, what are these copay accumulator programs, like how are they really impacting the market? So if you look at the percentage of purchases that are made with a copay card for drugs that have a generic equivalent. So this is kind of what the argument that others have been making about how it drives people to generic drugs. So we're looking at the whole prescription claims data information. These programs, or these payments that are made, again, that do have a generic equivalent out there, that represents 0.4%. So this is less than 0.5%. So really, it's a very slim portion of the market. I mean, tiny. But to the patients that rely on the copay assistance, it's huge. So it really gets to the argument that, those who are trying to found copay accumulator policies on a false claim that copay cards are distorting the market, and it's just incorrect. So then I'll move back up to the third point on the list. Most importantly, when issuers are implementing a copay accumulator, they are collecting money that has been covered by the copay card or through that copay assistance program. And then they're also collecting it when the copay assistance runs out. They've now collected the payments from the patient for this thing that should be for the same exact purpose or service or benefit. So essentially that means that they're collecting the payment twice, or they're double dipping. And again, that's just not right. It's keeping money for their bottom line when it should be going to the benefit of the beneficiary. All right. So hopefully you all stuck with me through this whole confusing and very nuanced policy issue. I just want to again say that the bottom line about copay accumulator policies is that they prevent patients from affording their prescription drugs. And these are drugs that are essential to their health and ultimately to their lives. So again, here's my information. I'm Stephanie. You can reach me at this email address. I'm happy to answer any questions outside of this forum. And then I've put up the where you can find that detailed report that I've mentioned many times on our website, or you can probably Google the AIDS Institute and Copay Accumulators, and hopefully it'll come up. But I think we now have time for some questions and answers. So I'll try and work my way through those if everyone can kind of be patient with me while I do some sorting. So I see right here about the, somebody had asked that they are interested in the additional information on how copay accumulators adjusters work. And again, I think that report gives a really good breakdown of it, more than what we could cover today, that walks through how they really work. In terms of who's keeping the money, insurance companies have claimed that they don't keep the money. However, there is no proof otherwise. So clearly it's not going to the benefit of the beneficiary. It's not being returned to the manufacturer, which is where it came from. So it seems to be kept by the insurance company. But again, a lot of information, especially from health insurers, is proprietary. So it's really a black box, and we just don't have insight into that. So until we can tell you otherwise, it seems to be being kept by the insurance companies. But there's nowhere else we can figure out that it would go. Let's see. Okay. Does that, another question was that, do accumulators apply to assistance from charitable organizations? So in some of the language that we have found on copay accumulators in the insurer's policy documents have been, at times it'll be more specific about manufacturer drug assistance, but there have been one or two instances where the language has been vague enough that it would include charitable foundations. But that tends not to be the case. I think we've only seen that once in Ohio. So charitable assistance still tends to be accepted and will count towards the patient's deductible. But I think one thing we want to note is that, all of these, even manufacturer assistance and especially charitable assistance foundations, it's a finite amount of money, and charitable assistance foundations are meant to be kind of a fail-safe. It's a last resort. And so if patients that had typically been using copay assistance from manufacturers, if they move over to more charitable foundation sources, that's going to strain those resources as well. And we are worried that issuers could make things more broad to include charitable foundation input too. Let's see. So I think I covered the legislation that has been introduced. We're hoping that in the next session of state legislatures that a lot of the states that I had put a list up, actually I can go to it here. Hopefully you can see that, where legislation was introduced, that those will be states that will continue the pressure and move forward with legislation. So that's really a good sign. I think, as I mentioned, with this current year, a lot of the state legislatures getting derailed by COVID-19, there's a chance that may continue into the next year and the next legislative session, and that a lot of the kind of responses that legislators will be focused on will be again tied into COVID-19 and kind of the repairs that will have to happen at the state level and such. So we're hoping that this could be framed in such a way because we think it is very important. It's you know, one of the many healthcare issues that are preventing people from getting their care and treatment. And COVID is just exacerbating all of these kinds of issues that exist. So there's potential that they could be introduced again in future legislations in these additional states. So we're pretty hopeful on that. Let's see. Sorry, I'm just trying to do a little scrolling. See if I can. So there's a question about if the issue of copay accumulator adjusters are more prevalent in high deductible health plans or just more damaging to patients. It doesn't seem to be, the research that we have collected, I should say, has not found that they tend to be in the higher deductible health plans versus other plans. I think if they're in there regardless of the high deductible health plans. What we are seeing is that the deductibles are increasing across the board. So even in a plan that would in the past have been a lower deductible plan, their deductible has been increasing as well. So I think the average deductible for 2021 was somewhere around 4,000 something, like maybe 4,500-ish. Maybe it was a little bit higher than that. However, when I was looking at through all the Florida health plans in particular, you know, I saw in one county in particular that the deductibles in their area, so this was across all the deductibles offered in this county, they were as high as I think $7,800, and there were multiple that were in the 7,000 range. So if the average is say 4,500 to 4,900, you still have a whole grouping that are higher than that. So that's pretty high. So it is damaging to patients either way, but the higher the deductible, the more damage it is, really. So there's a question about manufacturers joining the AIDS Institute and advocating to help with copay assistance. So manufacturers are aware of this issue. However, I would say that they've deferred a lot to patient advocate groups because I think from an optics perspective, they don't want to be involved because, you know, it would look as if it's benefiting them specifically. So, you know, we've had conversations. We've actually been trying to get more data from the manufacturers, which is difficult. I mean, it's just as difficult to work with them as it could be with insurance companies. But to gauge how many, not just how many people utilize copay assistance from their company, but if they're able to tell if patients have a copay accumulator in the plan. And I will say that this is kind of a side topic, but CMS actually released another rule that was actually related to Medicaid and Medicaid best price, which is how a Medicaid program or provider would get reimbursed for prescribing a drug. That had copay accumulator details in it. And so we're noticing that, you know, CMS is trying to find ways to kind of root out how they can impact copay accumulators potentially in the opposite way of what we want. So we're tracking what's happening kind of in all the different realms in the manufacturer world and CMS, and then from insurance companies as well. So I'll just say that. The question is it possible that the money, and I'm assuming this means like the copay assistance that I had mentioned, that we are unaware of, you know, if it's going anywhere but beyond the plan, the issuer, when they're keeping it and not applying it to the patient's deductible. So they're asking if the money could possibly be going to specialty pharmacies, and that is a very strong possibility. And I guess I'm not certain if specialty pharmacies in particular, or we know that pharmacy benefit managers in general are also advocates of copay accumulators. So on the opposite side of our stance on things, and often those pharmacy benefit managers are the ones who are instructing health plans to put a copay accumulator policy in their plan, because they're kind of on the same team. The PBM is kind of helping the plan to structure their pharmacy formulary, et cetera. And so then you also get into the issue of where a lot of health plans also now own the pharmacies like CVS Caremark, that kind of thing. So yeah, there's a chance that it is going to the pharmacy, and maybe the plan is saying that they're not keeping it, but it's all kind of in that same family, and ultimately still not going to the patient. So I don't know anything more than that, but that's a good question. So is there a consistent way to read your healthcare plan and to know if you have a copay accumulator policy? Unfortunately, I wouldn't say there is a consistent way. I think the most reliable way is to ultimately call a consumer representative from the plan and ask them. In my experience of researching these policies, when I had difficulty finding it in plan documents, most of the time, the representative was able to tell me pretty quickly, yes or no. So I would recommend that as really, an action item. What you can tell, either if you yourself are looking for this information in your own health plan, or if you're helping somebody else navigate the same issue. That's probably the quickest and easiest way to find this information. Other than that, I would say there's the most consistent way is to find usually the evidence of coverage or the summary of benefits and coverage are the two typical document names that you're looking for, and they're going to be large documents. They'll be, at minimum 40 pages, but typically 100 pages, give or take. And what I do is do a Control F. So if I have a PDF of the document, I would search for keywords like, here's the other kicker, it's not going to be listed as a copay accumulator. But I would look for words like manufacturer assistance or deductible is hard because that's often written in there multiple times, but usually manufacturer assistance would get me closest. And then I would also just I read many a pharmacy benefit within those documents and try to just look for, I would narrow it down to that section of pharmacy benefits, and then see if I could find anything that looked related to copay assistance. I think a good key would be to go back to either the report or that has this information from the slides that I shared with the language. And again, look for kind of key phrases that are recurring amongst those policies and do a similar search. But again, your best bet is really to call. Do you see anything going back to the federal government to ban this on ERISA plans? So I guess to give a little more information on ERISA plans are the large group market plans. So what we've been talking about are the individual market plans or small group health plans. So if you have like a small business, you might have a couple employees that you offer health insurance and they can buy it on the marketplace. But ERISA plans are the big plans, and they are governed by other rules from the federal government. And that good NBPP, the one that came out last year for the 2020 NBPP, that good one was, I didn't mention this, but it actually had extended to ERISA plans and those large group market plans. So it was much broader regulatory step, which was really great. So not only was it going to help protect individuals who are shopping for their health insurance through the ACA, it would impact other plans. when that got walked back in that August FAQ, that was also walked back. So in terms of, whether we think that the federal government might do something in terms of ERISA plans on this, I am not certain that things are going to happen in any realm for the immediate future. I think, if things change in the next year or so, and there may be individuals who would be more sympathetic to this issue, we could revisit that and bring that back up. But otherwise, I'm not certain. For now, I think, another idea would be, as momentum is gained in the states, as more and more states pass legislation, there could be pressure, and again, at the federal level for both the individual market plans and these ERISA plans. Have manufacturers provided data on how much money has been paid to insurance companies that didn't actually go to the patient's copay? No. So I think some of that would come from the claims data, but as far as I know, the manufacturer is not aware whether or not, basically, when the copay assistance is, how it's being used. I think depending on the way in which the assistance is distributed to the patient, can then, it may vary how the manufacturer themselves can track how that assistance has been used. But if they have access to it in terms of, like, say there's kind of like a debit card in some cases, a copay card, where there's a finite amount of money, say $10,000 on it, they can maybe see that the assistance is going down on that card, just like a debit card. It's now down to $2,000, but they don't know that it's gone, who it's gone to. That would really, I think, come from the insurer, which again is a black box of information. Oh, right. So that's a good question about, somebody had asked about the use of copay cards in government programs, for example, Medicaid or Medicare, that they're not eligible to use copay assistance. And that's a really good point and question, in that when I mentioned the Medicaid best price rule. So you're correct. You cannot use copay assistance in those programs, Medicare and Medicaid. And that's where it kind of became confusing in the best price rule. So it was kind of unrelated. So it's not about the fact that in that copay cards are being used in Medicaid in particular, but it's all the calculation behind the scenes that determine what that drug's best price is. And they were trying to include, if there's a discount, such as a copay card, or sorry, the copay assistance that's being used, that would factor into the calculation. So it's not, in fact, that people are using the copay assistance in Medicaid or Medicare, but it's that behind the scenes calculation for the reimbursement cost for the drug. So that was a really good question. And the second part of that question is, why would Medicaid include this language? We think it's kind of not Medicaid specifically, but CMS trying to get rid of copay get rid of copay assistance and kind of force manufacturers to give up those programs is our interpretation. Let's see, sorry, I'm just gonna do a little more scrolling and check on our time. I think we have about 5 minutes left. Oh, so sorry, just doing a little reading here on this questionnaire. So it sounds like there's somebody who has done the same process of digging through the policy documents, and that they also did a Control F for coupon using keywords, and that they were able to find that information in their plan document. But it's true, it's really hard to find, and yeah. Sorry, I'm reading and thinking and talking at the same time. They're just saying that it was, they ended up having to do some follow-up with the consumer representative or the assistants or consumer rep to find out really how the policy was being implemented. And I think that, the other thing is that we don't have insight into is if these policies, so even if an insurer has a copay accumulator policy in their plan structure, and we know that, based on their information that they've provided and the documentation, it's not clear as to how they're implementing it. There is a chance, and what we've been worried about, but we don't know if this is baseless or not, is that they could be potentially implementing the copay accumulator on your drugs for hemophilia, but not for my drugs on HIV, or for so-and-so's drugs on MS. We're not certain if it's being implemented uniformly and broadly, or if it's being selective in any shape or form. Again, it's all just incredibly opaque in how these are being implemented and how they've been structured. So it's a worry of ours. I don't know if it should be a worry or not necessarily, but it's just helps our argument in terms of, are they discriminating? Is there a potential for discrimination in the way in which these policies are being implemented? And I don't know how we would find that out. Oh, sorry. Trying to just do some scrolling. So it looks like there was some follow-up about legislation disallowing manufacturer assistance in Michigan. I'm trying to think if I know that. I think also Michigan might be one of the new states that is leaning towards introducing legislation. So stay tuned for that. If you have folks that other advocates in the state that you want to connect with, that would be great, and or feel free to reach out to me. I can help connect if I know any folks that are working on that issue there. But looks like we're getting very close to time. Again, I want to thank you all for sticking with me. Hopefully this was clearer than the way in which the policies are implemented. And feel free to reach out to me via email after this if you'd like to. I welcome any more questions, and thank you again. Have a great night.